We are live.
Good evening, everyone. Welcome to iFocus Online, lecture number 554, module Optics and Refraction number 29. Today we have Dr. Ritica Mukherjee from Center for Sight, Prayagraj, who will be talking on BVD, muscle balance test, IPD, decentration of lenses, and prismatic effect. The moderator for today's session is Dr. Savita Arun. Ma'am has done her MBBS from Bangalore Medical College and DOMS Ophthalm from RIO Minto Eye Hospital. She has done DNB from Prabha Eye Hospital and fellowship in general ophthalmology and FECO at Netradam Eye Hospital, Bangalore, plus PGDHA in hospital administration. Ma'am is also Director, Medical Superintendent, Senior Consultant, and Quality Assurance Coordinator at Netradam Hospital Private Limited. She is also NABH Assessor for SHCO. Ma'am is also Principal of Netradam School of Optometry and Faculty for DNB, Phaco-refractive, glaucoma, and cornea fellowships. She has trained doctors and optometrists nationally and internationally. Ma'am is trained in Germany for electrophysiology. She has multiple scientific papers, including work on multifocal ERG, anti-VEGF response, amblyopia therapies, and has presented at national and international conferences. She is a recipient of several quality educational and service awards like Qualtech Prize, IMC RBNQA recognition, Most Popular Award, Special Education Award, and she has contributed to NABH accreditation achievements. We welcome you, ma'am. Over to you for introduction of chairperson and speaker for today.
Namaste. Good evening.
Kaveri, I think you haven't shared the slides.
Yeah.
Is it visible now?
Yeah, sirs is visible. So, shall we start? Namaste. Good evening. Thanks a lot, Dr. Kaveri, for your kind introduction. A warm welcome to you all for the iFocus 2025 Optics and Refraction module webinar. The topic is BVD, Muscle Balance Test, IPD, Decentration of lenses and prismatic effect. Optics and refraction, as we all know, forms a core foundation of ophthalmic practice and a subject that continues to evolve with advances in diagnostic technology and refractive solutions. Whether one specializes in comprehensive eye care, pediatric ophthalmology, cornea, glaucoma, or retina, a strong understanding of optics helps refine clinical decision making, improve refractive outcomes, and enhance patient satisfaction. It is my privilege to introduce distinguished chairperson for today's webinar, Dr. Neeraj Kunghar, and a warm welcome to you, sir. Sir has done MBBS and MD from All India Institute of Medical Science, New Delhi. Currently senior consultant at Center for Sight Eye Hospital, Ajmer. President-elect of Rajasthan Ophthalmic Society. He has served as Chairman Scientific Committee of Ajmer Ophthalmic Society and Organizing Secretary of Ross Conference 2013 at Ajmer. One of the pioneers in phacoemulsification surgery in Rajasthan, participated as faculty in live surgeries in phaco and SICS workshops, and has multiple presentations Sir has multiple presentations as faculty and he has presented surgical videos. He is a recipient of Gold Medal for Distinguished Services. A warm welcome to you, sir. And I'm delighted to introduce today's speaker, Dr. Ritica Mukherjee. She has done MBBS in 2016 from Rohilkhand University, Uttar Pradesh, MS Ophthalmology in 2021 from Jawaharlal Nehru Medical College, Maharashtra, Fellowship in Cataract and Refractive Surgery from Narayan Netralaya, Bengaluru. She is a ratified member of the All India Ophthalmic Society and Delhi Ophthalmic Society. She has published articles in national and international journals and has won Best Paper at International CXL Meet December 2022 at Zurich, Switzerland, and Best Poster at ESCRS, Vienna, Austria. She has also received Shiva Prasad Hardya Award, in refractive surgery conference. And a warm welcome to you, Dr. Ritika Mukherjee. We A warm welcome to all the participants, and we encourage you to share your questions and insights in the chat box, and they will be addressed at the end of the session. Over to you, Dr. Ritika.
Thank you, ma'am, for the warm introduction. I would also like to thank Dr. Santosh Honava, sir, for the opportunity to present at this platform. I'll just be sharing my slides. Are my slides visible?
Yes, they're
Yes.
visible.
So today's topic is, I think, one of the last lectures in the optics and refraction, in the clinical refraction part. And so it's a mixed bag of topics, not necessarily related, but all of them play a role when dispensing spectacles. I will try to simplify it and explain with examples the different topics that we are going to discuss today. Some of them also have practical importance because you may be asked to describe how we can calculate the IPD in an OPD setting, how we can calculate the back vertex distance. So I'll be covering those topics uh, under the following headings. So the first thing we'll be discussing is the back vertex distance. What is the back vertex distance? It is basically the distance between the front of the cornea and the back of the spectacle lens, as you can see here. Usually, the standard vertex distance is of 12 millimeters, used by most phoropters and autorefractometers. Now, why do we need to measure this distance? Because if there is a difference in this distance, it can alter the effective power of a spectacle lens. Because the eye is a self-focusing system, any lenses which is placed in front of it will be perceived by the brain as having more or less strength depending on the distance that that lens is present in front of the eye. And this distance may not be the same as the one which was used by the autorefractometer reading, which was used to make the spectacle lens, because a person may wear a glass close to the eye or slightly further away. And this is especially true for higher powered lenses, especially those more than 4 diopters. So for those lenses, we definitely need to check the back vertex distance. Now, how can this be measured? Historically, the instrument used to measure the vertex distance was called the distometer. And in this, we basically ask the patient to close their eyes. The device, as you can see, is placed between the lid and the spectacle lens. The plunger is slowly pressed so that the two ball ends separate. When they touch the lid as well as the back surface of the lens, we read the marking on the scale. We may add a millimeter or two to account for the thickness of the eyelid, and this gives us the back vertex distance. The second way we can measure is through a stenopic slit. We can pass a thin paper ruler through the slit to touch the closed eyelid. And the distance between the stenopic slit and the eyelid is the vertex distance. So it is around, and we need to add 1 to 2 millimeters for the closed lid as well. The simplest method and most commonly used in the OPD is using a millimeter ruler to measure from the back of the spectacle lens to the front of the cornea. If we can't see the back of the lens, we can always measure from the front of the lens and then subtract the lens thickness. Now, there are certain rules when we are measuring the back vertex distance. This differs for plus as well as minus lenses. So, a simplification of the rules is when we increase the vertex distance of a plus lens, it will increase the effective power of the lens. When we decrease the vertex distance of a plus lens, it will decrease the effective power of the lens. And this is opposite for minus lenses. Increasing the vertex distance in this case will decrease the effective power of the lens, and decreasing the vertex distance of a minus lens will increase the power of the lens. Apart from this, decreasing the vertex distance increases the field of view. So as you can see in this diagram, when we move the lens backwards, that is, we decrease the back vertex distance, we are automatically increasing the field of view. This is why in contact lens users, the field of view is more, because in that case, the back vertex distance is 0. Apart from increasing the field of view, The changes in image size are also reduced when the back vertex distance is 0. So, for example, in glasses, there is a magnification or a minification of images based on the plus or minus lens. However, with contact lenses, this is reduced. So, these are certain rules, and now we'll be understanding how we can calculate the vertex compensation power. Vertex compensation power is basically the effective power after we have altered the back vertex distance. So a simple formula for this is, as you can see on your screens, DE being the power perceived by the wearer or the effective power, DL being the actual lens power which was prescribed to the patients, and a small d being the change in vertex distance. So let's try to understand this with an example. So a person may be sitting at an auto refraction device which determines that the person needs a minus 8.75 diopter spherical glass in order to see clearly. So this device was set at a default vertex distance of 12 millimeter. However, when the customer chooses a frame and you measure the frame, you find that it actually sits 15 millimeters away from the eye and not 12. So in this case, the back vertex distance is 15 millimeters. So now we have a difference in the worn position of 3 millimeters, or if you consider it in meters, 0.003 meters. So the spectacle lens is lying 3 millimeters away from the eye. Now the rule states that if we increase the vertex distance of a minus lens, it will decrease the effective power. And if we decrease the vertex distance of a minus lens, it should increase the effective power. So using the formula we just discussed, we can see that the effective power is minus 8.53 because we have decreased the vertex distance. In this case, sorry, we have increased the vertex distance. The effective power of the lens has decreased. We have taken minus sign over here because the lens is moving further away from the eye. So in a compensated lens design, the lens when it is being designed will actually be made at minus 8.53 so that the patient perceives a power of minus 8.75 when he is wearing the spectacles that lie 15 millimeters away from the cornea. Another thing that we calculate is the vertex compensation formula. It gives us the compensation per millimeter of displacement away from the cornea per diopter of lens power. So the formula is D2 by 1000, and the result that we get is either added or subtracted from the power according to the following set of rules. So we add this value when the plus lens is moving closer or the minus lens is moving further. We subtract it when the plus lens is moving farther or the minus lens is moving closer. Let's understand this with an example. For example, a patient has a plus 12 diopter power and the distance that it is moving closer to the eye is 4 millimeters. So the back vertex distance is decreasing by 4 millimeters. So here the power is 12. So when we calculate according to the vertex compensation formula, we get a value of 0.14. Now this is for 1 millimeter of displacement. We have 4 millimeters of displacement. So we multiply that. So approximately 0.5 diopters need to be added. Why are we adding this? Because in this case, a plus lens is moving closer. So we need to add this value. So we add 0.5 and this plus 12.5 will be the actual effective power based on the vertex compensation formula. So there are two formulas basically which we can use to calculate the effective power. Usually optometrists will have a table with these powers already calculated. So this is just to know how that calculation value has come. Now, when can the vertex distance vary? So contact lenses fit right on top of the cornea, and so there is virtually no vertex distance. This can be problematic because, like we discussed, most autorefractometers will have a back vertex distance of say 10 to 14 millimeters. So this is why whenever we are calculating contact lenses for plus or minus 4 diopters, we need to compensate for the vertex distance. Now, as you can see a vertex distance conversion chart here, most optometrists will have this, and this has been calculated with the formulas we just discussed. However, it is still important that the person comes to an ophthalmologist or an trained optometrist to get the contact lens fitting, because sometimes a minus lens is created by the tear film itself. So it should not be based just on the conversion chart. We should individually test the contact lens for the patients before prescribing. Other examples of where the vertex distance can vary is if a patient has a high bridge nose. So you can see here the lens will actually be sitting, the will be sitting slightly closer to the eye, because the patient has will be putting the glass just over the bridge of the nose. And if the patient has a very deep set eyes, because of the superior orbital rim, the glasses will sit slightly further away. So the back vertex distance may change in these cases as well. The next topic that we'll be discussing is a muscle balance test. So whenever we give a final prescription, we should always check for oculomotor balance, both for distance vision and near vision, and with and without the correction in front of the eyes. The things that we should be checking for are any manifest deviation, any heterophoria, the type and degree, presence or absence of a conversion insufficiency, as well as the fusional reserves. These should be discovered and they should be given due attention in treatment, because if we prescribe glasses in the presence of these problems, the patient may complain of eye strain. Now, as you can see here, the tests for assessing oculomotor balance are, there are quite a few tests, and it's outside the scope of this lecture to discuss all of them. So I'll just be discussing two tests that we can do in the OPD just to discover whether or not the patient has oculomotor imbalance. So I think cover uncover test is the commonest that we can use. So here you can see if a patient has a frank esotropia. Over here, the patient has a frank esotropia in the left eye. If we cover the right eye, we can see that the eye moves outwards. So this indicates an esotropia. Similarly, if the patient has an exotropia of the left eye, if we cover the right eye, we can see that the eye moves inward. Again, for left hypertropia, we can see when we cover the right eye, the eye moves downwards. And for left hypotropia, we can see that when we cover the opposite eye, the eye moves upwards in order to fixate. This movement is because the eye with the phoria, heterophoria, tends to move to fixate once we cover the normally fixating or the dominant eye. An alternate cover test can be done to diagnose whether a patient has a alternate squint or not. However, there are certain limitations for cover tests which may be overlooked, because if there is a small heterophoria or a very small angle esotropia, a microtropia, a monofixation syndrome, or a cyclodeviation, the cover uncover test may not pick it up. For very slight deviations, we can also do a Maddox rod test, because that is easily available in the OPD. So here you can see when there is no horizontal. So we need to understand what a Maddox rod is. Basically, it is a collection of red cylindrical tubes which are oriented in the way that you can see. So here they are oriented horizontally. Now what happens when you look through a Maddox rod is, if you're looking at a point source of light, the Maddox rod will convert it into a red streak of light. So when a patient sees through, when an orthophoric patient sees through this Maddox rod, he will see a pinpoint light along with a red streak. Now this red streak which is formed is perpendicular to the direction of the tube. So here when you can see that the tubes are directed horizontally, but the vertical streak will be seen by the patient. So this is a typical example when a patient has orthophoria, when there is no horizontal ocular deviation, the patient will see the point source of light through the red line in the straight gaze as well as the right and left gaze. When the patient has an ESO deviation, that is, in this example, you can see that the patient has a right abduction deficit. That is, the eye is moved, has moved inwards. It is not able to move out. So when such a patient sees through a Maddox rod, he will see a vertical red line that appears slightly away, that is to the right of the point source of light. It will appear to be on the right of the examiner. For the patient, it appears to be on the left, but for the examiner, he will say that it appears to be on the right. When the patient sees in the right direction, this gap between the point source of light and the streak of light further increases because the patient has a right abduction deficit. When the patient looks towards the left gaze, then he is able to see the point source of light passing through the through the red streak of light. Similarly, if the patient has a left adduction deficit, so we are all of this discussion is with the problem being in the right eye. It may also be in the left eye, which will be diagnosed when we put the Maddox rod in the other eye. Right now, we are only discussing about problems in the right eye. So here again, in the left adduction deficit, the vertical red line will appear to be on the left of the white point source of light when the patient's right eye is placed under the Maddox rod. When the patient looks to the right, this deviation increases further. The distance between the point source of light and the red streak will increase further. And when he looks towards the left, it will again appear to be in line with the white dot, white source of light. So this helps us to understand if there is any minor deviation and any minor horizontal deviation of the eye. Similarly, we can do this test to assess vertical deviations as well. To assess a vertical deviation, we need to place these rods vertically in front of the eye. Here we had, here we had placed the rods horizontally and the image formed was vertical. But to assess vertical deviations like hypertropia or hypotropia, we need to place the Maddox rod such that the cylinders are directed vertically and the image formed will be horizontal. So when the patient is orthophoric and the Maddox rod is placed in front of the eye such that the cylinders are vertical, the patient will see a white light passing through the horizontal red line, which is normal. If, however, there is, say, a right hypertropia, when we tell the patient to look in the straight gaze, we will see that the red line appears below the white light, indicating that the right eye is slightly higher than the left eye. That is, there is right hypertropia. So this can help in diagnosing even partial deficits in the left eye. For example, if there is a partial left third nerve palsy, which may not be very apparent on cover uncover test, Maddox rod will help pick that up as well. In the up gaze, this distance between the red streak and the white light will increase further. And when the patient looks down, it will again come back to the normal position where we see the red streak along with the point source of light. So this is a test that we can do in the OPD just to see if the patient has a ocular imbalance or not. And if yes, then that needs to be treated or addressed by either inducing a prismatic effect so that the eye can move in the desired direction. We'll be talking about the prismatic effect later in this lecture. The next topic that we're going to discuss is the interpupillary distance. So what is the interpupillary distance? It is the horizontal distance between the right and left optical centers or CP of the eye. One second. And this or it is also known as the central distance or the interpupillary distance. How do we measure it? It can be measured as the distance between the center of the pupil of the eye, and it is measured in millimeters. It does not necessarily have to be the center of the pupil. We'll be talking about that. So certain instruments have been used to measure the IPD. So we can measure the IPD either by measuring the visual axis distance, that is the horizontal distance between the two visual axes, or by measuring the center point of pupil. Currently, Bishop-Hartman rule is very commonly used, or the PD scales are very common. We may even use a simple millimeter scale to measure this. So why do we need to measure the IPD? If we don't measure it accurately, it may result in misplacement of the optical center of the lens. So all spectacle lenses have a certain optical center or the datum center. We'll be discussing what that is. If the IPD is not measured carefully, the optical center of the glasses may differ and this can induce a prismatic effect. So this may require the patient to turn their eyes inward or outward to avoid diplopia because it is inducing an effect like a prism. And over time, if the patient continues to look through these lenses with an incorrect IPD measurement, it can cause visual discomfort and asynopia. So we may get patients in our OPD who have the perfect power, and once the optometrist checks, he again says that no, the power is correct. So these issues might still be causing asynopia or discomfort in the patient. This is a small video explaining how to measure the IPD. I'll be discussing it in detail after we see the video.
We're looking to measure the distance between the patient's pupils. So first, we close our right eye and we get the patient to look directly into our left eye, and we line up the PD rule with the temporal side of the patient's pupil. Next, we swap over to our right eye and we get the patient to look directly into our right eye, and we see at what distance the nasal side of the pupil is according to the ruler. Then we double check our measurements, swapping back to the right eye, ensuring that the temporal side of the pupil is still lined up with the 0, and then back over to the temporal side to recheck our measurement. We're going to measure monocular pupillary distance using the center of the nose as our reference point. So the setup is the same as it was for our binocular pupillary distance. We're going to get the patient to look into my left eye whilst we're staring at their right eye. And then we're going to be measuring the distance from the center of the nose, which according to this ruler, we have the 0 over the center of the nose, over to the center of the pupil. Next, we're going to swap over to the left eye and get the patient to look directly into our right eye. Again, we're measuring the distance from the center of the nose, which is denoted by the 0 on the ruler, over to the center of the patient's left pupil. Here we see a left pupillary distance of 31.5. We're going to double check the measurement of the right eye, and then double check the measurement that we're getting for the left eye. Now we're going to measure near pupillary distance. We're going to assume a reading distance of 40 centimeters from the patient. So I'm going to sit and set myself 40 centimeters away from the patient's eyes. I'm going to use just my right eye for this measurement. So I'm going to get the patient to look straight into my right eye while I place the PD rule with the 0 mark on the temporal pupil. Next, I'm going to have a look at the left eye and note at what distance the nasal side of the pupil is on the ruler. To double check my measurement, I'll look again at the right eye, making sure that the temporal pupil is still over the 0 mark, and then I'll recheck my measurement on the left eye. Notice I didn't swap eyes, and I got the patient to look at my right eye throughout this procedure.
So I'll be discussing this again. We'll be talking about binocular pupillary distance, monocular pupillary distance, and the near pupillary distance. So whenever we are measuring the PD, we can do it in 3 ways. We can either measure the horizontal distance between the center of the pupil as denoted by A, or we can measure the distance between the right temporal pupillary margin to the left nasal pupillary margin, or the distance C, which is the right temporal limbus to the left nasal limbus. So how do we measure it? The simplest method is by using a millimeter scale. Here the examiner will sit at a distance of 40 centimeter or 16 inches from the patient, and the examiner closes his or her right eye. Now the patient is asked to look with both eyes to the examiner's open left eye. And when the patient is looking here, we will mark the 0. Now this 0 mark can be coincided to the center of the pupil or to the temporal border of the pupil of the patient's right eye. The next step will be to close the left eye. That is, the examiner closes their left eye and opens their right eye and asks the patient to focus on the examiner's right eye. That is your right eye. And now we will mark the center of the pupil or the nasal border of the left pupil. This gives us the IPD. In order to cross check, we can again close the right eye and check that our 0 mark is at the same point where we had measured it initially. If you had measured it at the temporal margin of the right pupillary border, it should still be there. And then again, you can close the left eye, open the right eye and check the value. So we can do this 2-3 times to cross check. This will give us the binocular pupillary distance. Now, how do we check the monocular pupillary distance? So the scale which was used in the video is seen in the image above. You can see that here you can just place it simply over the bridge of the nose, which gives us the 0 mark. And then you can go on either side and measure the IPD by seeing where the center of the pupil lies. The other way to measure is, in this we need to take the center of the pupil as reference point. We cannot take the temporal or the nasal margins. Before moving the ruler, we need to note the reading at the center of the nose. So it will be the same measurement the way that we did the binocular IPD. So we will close our right eye and we will ask the patient to look at our left eye. We will mark the 0 and then we will before we open the right eye, we will note the value at the center of the nose. This will give us the monocular PD. And then we can again go to the other eye and measure it, or we can subtract it from the binocular reading. Why do we need to measure the monocular PD? It's because in most cases, the faces may not be perfectly symmetrical. So it's better to measure the monocular PD and then combine it to get the binocular PD. So near pupillary distance is required for single vision reading glasses or for multifocal lenses. Why? Because whenever we are reading something close by, our interpupillary distance changes because our eyes converge. Now the near pupillary distance can either be measured or it can be calculated. So first we'll talk about measuring it. So for this, the examiner places his or her dominant eye in front of the patient's nose. So for this example, we can assume that the right eye is the examiner's dominant eye and that is placed right in view of the patient's nose. Then the examiner closes the non-dominant eye. So in this case, the right eye remains open. And the patient is asked to fixate on the examiner's open eye. This causes the pupils to move inwards, giving us the near pupillary distance. So how do we measure this? Once the patient fixates on the examiner's right eye, we will place a 0 point of the PD ruler at the center of the patient's right pupil. Left eye is still closed, only our right eye is open, and we will mark the center of the pupil, giving us the 0 mark. After that, we will read the scale at the center of the pupil of the patient's left eye without opening our left eye. Our right eye is the only one which will be open when taking this distance. So first we will mark the 0 and then we will move our eyes to the patient's left eye and mark the center of the pupil, giving us the near IPD. And during this whole procedure, we have to make sure that the patient is focused on our nose. Only then we will get the near IPD. We can also calculate the near IPD using something known as the 3/4 rule. This rule states that for every diopter of dioptric demand, the pupillary distance of each reading lens is decreased by 0.75 or 3/4 millimeters. What is dioptric demand? It is basically the inverse of the reading distance. So we'll try to understand this with an example. Suppose a spectacle wearer has a reading distance of 40 centimeter and has been given the following prescription. His pupillary distance of the binocular PD is 64 millimeters. So what will be the near PD for this patient? We can calculate it using the 3/4 rule. The dioptric demand for this patient will be 1 upon 0.4 because 40 centimeters is his reading distance. So it's in meters. So we'll do it this way. This gives us a value of 2.5 diopters. So we need to insert this per lens. So 2.5 diopters into 3/4, which is the rule. We need to decrease by 3/4. So for basically for this was for every 1 diopter, we need to go 3/4. Here we have 2.5 diopters of dioptric demand. So we need to multiply that by 3/4 and that gives us approximately 2 millimeters. Now this value has to be subtracted from the distance IPD. So our distance IPD was 64 millimeters. So the near IPD in this case will be 60 millimeters. So what are the common problems we face when we are measuring IPD and how can we solve them? Basically, the dispenser or the examiner may not be able to close one eye, in which case we can occlude the eye with the free hand. We may not be able to just close it. And if the subject is strabismic, then we can cover the subject's eye which is not being observed so that he is able to fixate. If the subject is uncooperative or a child, we can also take canthus to canthus measurement. And in cases of isochoria, the distance between the temporal border of the right pupil and nasal border of the left pupil. And similarly, the distance between the nasal border of the right pupil and the temporal border of the left pupil is measured. So we will take 2 readings in this case, and the average of these 2 readings can be taken as IPD. Coming to decentered lenses and prismatic effect. So something that we need to understand to know what is decentration of lenses is the datum system. The datum system is an old British system of giving spectacle measurements. It has been overtaken by the ISO measurements, but for definitions, we need to know what a datum center is. So basically, you can see here a spectacle lens, a cat's eye lens. The datum line is basically a line passing midway and parallel to the horizontal tangents to the lens shape. So this is the highest point of this lens given by HH, and JJ gives us the lowest points. So midway between this is what is known as the datum line. What is the datum length? Basically, you can see that the datum line is extending further than the actual lens periphery. So when we take the portion of the datum line which is going from actual lens periphery from side A to side B, that gives us the datum length. And the center of this length is known as the datum center, and it refers to the midpoint of the datum length. We can also call it the optical center. So what is a decentration of lens? A lens is said to be decentered when its optical center, when the optical center of the eye does not correspond with the datum center of spectacles. So basically the visual axis is the optical center, and if it is not corresponding to the datum of the datum center of the spectacles, that means that the lens which has been made is slightly decentered. Now, what can be the causes of this decentration? It can either be intentional or unintentional. It will be intentional when we are purposely decentering the lens to account for near work. So sometimes when the optician tells you that we have decentered the lens so that the patient is able to work on the screen, that means they have slightly changed the center of the lens so that the patient can look at a certain distance without compromising on the clarity of vision. We can also do this to produce a prismatic effect at the optical center in cases of heterophoria. So like we discussed, we can induce a prismatic effect in patients who have a heterophoria so that by inducing a prism-like effect, the eye moves towards the center and the heterophoria can be corrected. So these are two examples where decentration is desired or intentional. And the third is when a patient's IPD does not correspond with the datum center distance of the chosen spectacle. So, for example, a patient chooses a spectacle where the datum center is not aligned to his visual axis, or if he naturally has a smaller IPD, so the spectacles which he has chosen, in that the optical center of the eye is, or the visual axis is not corresponding to the datum center of the lens. This is an example of an unintentional decentration. So what is prismatic effect? It basically means creating a prism effect by purposely decentering the lens. So whenever we are decentering lenses, it will cause formation of a prism in the lens. And as we know, all prisms have a power and have a direction of the base. All prisms have an apex and a base, and the direction of the base tells us where the eye will move. So commonly, the most common rule for prisms is that the light rays move towards the base of the prism, and so the image moves towards the apex. We need to remember that while we discuss the next few things. The power of the prism depends on the amount of lens decentration, and the refractive power of the lens being decentered. So how do we calculate this? We use the Prentice rule. It can be calculated with a simple formula. Basically, the prism diopter is equal to the power, the prescription power in diopters multiplied with the decentration distance, that is the distance from the optical center. We'll be discussing this using an example. But first, let us understand what the prism base orientation means. Whenever we are decentering lenses, we are also changing where the base of the prism lies. To understand this, we need to understand that a plus lens or a concave lens is essentially two prisms that are arranged base to base. And when we talk about a minus lens, it is basically two prisms that are arranged apex to apex. So whenever we are talking about a base, so in the images that you can see right next to the lenses, you can see that there is no prismatic effect. They are not decentered. But once we start decentering, we can see that the center of the pupil in the C image just below the plus lens, we can see that the center of the pupil or the optical center or the visual axis lies nasal to the base of the prism. So in this case, we call it a base out prism. That is, the optical center of the glasses is wider than the pupillary distance. This is for plus lens. And for plus lenses, base in prism is said to occur when the optical center is narrower. That is, the optical center of the glasses lies closer together than the interpupillary distance. This is known as a base in prism. For a base up prism, the optical center for that eye. So here we can see that it's mentioned as right eye because you can see in the right eye, the optical center lies above the visual axis or the pupillary distance. Similarly, for a base down prism, it will lie, the optical center will lie below the visual axis. And it is opposite for a minus lens, where you can see basically the difference will come because in a minus lens the apex is at the center, and in a plus lens it is the base which is at the center. I know this is slightly tough, but I will be trying to explain this with a simple rule. If you simply want to remember where the base direction of a spherical lens decentration will be, you just need to know two rules. If the lens is a plus, then the induced base direction will be towards where the lens has been decentered. And if the lens is minus, then the induced base direction will be opposite to the lens decentration. What does this mean? So for example, if we consider a plus lens, if a plus lens is decentered downwards, that means that the eye will be seeing through a point which lies above the optical center of the lens. Why? Because as we discussed, the image in a prism will always be moving towards the apex and away from the base. Here we are moving the base of the prism downwards, so the image will be going upwards. So that is why this is creating a base down prism, since the image is being formed upwards. And and the exact opposite of this will be if a plus lens is centered upwards, if it's decentered upwards, the eye will be seeing through a point which lies below the optical center, because again the image will be moving towards the apex and away from the base. So in this case, we will be creating a base up prism. That is what it means. Again, for a plus lens, if the plus lens is decentered outwards, that is away from the nose, the eye will be seeing through a point which is nasal to the optical center, and this will be known as a base out prism. Again, this is base out because the image will be formed towards the apex, or in this case, nasally. And if a plus lens is decentered inwards, that is, the optical center is moved towards the nose, then the eye will be seeing slightly temporal to the optical centers, and in this is known as a base in, base being this portion of the lens. So it is a base in type of lens being created. The same principle applies for a minus lens. Whenever we are decentering downwards in a minus lens, you can see over here that the eye will be seeing through a point which is above the optical center because the base is up. Why? Because in this case, the apex is directed downwards. So the eye is going to try to go, the image is going to be tried to form towards the apex. And that is why the base will be up. Again, if a minus lens is decentered upwards, the eye will be seeing through a point which is below the optical center, because like we discussed, again, the image has to be formed towards the apex, and this creates a base down prism. Again, when it is decentered outwards, the eye will be seeing through a point which is nasal, and a base in prism will be created. And again, when the optical center is decentered inwards for a minus lens, the eye will be seeing through a point temporal to the optical center, and so the base out prism will be created. We can understand this using a case example. For example, if a lens has a power of +3 diopters and it is decentered 5 millimeters out from the center of the eye, for whatever reason, suppose the patient has heterophoria and the lens needs to be decentered away so that we can correct the heterotropia, and the amount of decentration is 5 millimeters. So how much prismatic effect are we inducing and what base direction will this cause? We know the formula, that is the Prentice rule. We know that the power in diopters is +3 diopters and the distance that needs to be moved is 5 millimeters. This needs to be converted to centimeters, so 0.5 millimeter. So according to the Prentice rule, the prism diopters needed is 1.5. Now, base direction, because it is a plus lens and decentered outwards. So like we discussed in a plus lens, if it is decentered outwards, the eye will be seeing through a point which is nasal to the optical center. And so this will create a base out prism because the apex has to be directed inwards, because the eye is seeing nasally or towards the apex, like you can see in this image. And so a base out prism will be created because the visual axis is nasal to the optical center. So the final prism diopter needed is a 1.5 prism diopter base out. So whenever the lens or the glasses is being created, this is the prismatic power that needs to be induced in the lens. That is all. I hope I was able to simplify this. If there are any questions, I'll answer them now.
Very nicely covered. I think you have very meticulously covered all the points. Just I like to add one thing, that when we are talking about muscle imbalance and prismatic effects, there is one more form of BVD that we talk about apart from back vertex distance, which you have very nicely covered. That is binocular vision dysfunction. So I think it is worthwhile that if I briefly mention about binocular vision dysfunction, when we are talking about muscle imbalances, when we are using talking about prism effects and all. So what is binocular vision dysfunction? That means there is some amount of micro tropias, basically either esotropia, hypertropia or something, which is creating a problem in the binocular vision. So these type of patients, many a times in our OPD, when I come to practical part of that, the patients will come with mild dizziness and with mild headache, or the patient may come with slight vertigo. Now, once these type of patients come, it becomes our duty that we have to do all these muscle imbalance, everything that you have discussed in detail in a very meticulous way. Because before we tell, because what are the other causes for dizziness and vertigo? They can be an inner ear disease, vestibular disease, or it can be a Meniere's disease, or it can be a caustic neuroma, or it can be a CP angle tumor. So all these other conditions will cause acute vertigo. It will not be a mild vertigo. It as it a patient may present in case of binocular dysfunction. But we have to rule out that when a patient comes with mild vertigo to us. So that is one thing that I wanted to add into this. And over to Dr. Savita.
Thanks a lot, sir, for your insight and input. Thank you, Dr. Ritika. That was very illustrative, and you have given practical tips. I want to, can you, for the benefit of the viewers, can you add a little bit on the size of the spectacle one has to select? Because decentration depends on that also, and some patients, if they don't select the size of the frame properly, then there will be some dissatisfaction. So can you just add something about the size of the
Definitely.
spectacle?
Yes. So first thing would be basically getting frameless glasses if there is a if the wide to wide distance is slightly smaller, you can get frameless glasses. However, if the power is very high, you should try to get slightly larger size glasses. Getting a cat's eye or a rectangular frame will not be a good idea in those cases. In those cases, you should get bigger rectangular frames or slightly square frames, because that also increases the field of vision. Of course, if you're a high myope, then going for a contact lens is the better option, because the field of view is increased. Again, we also need to consider the pin cushion effect, which happens when you are wearing square shaped glasses. So, to avoid that as well, contact lenses would be the answer. Getting the thin rimmed rectangular glasses is a bad idea, because even if they are frameless, the field of vision reduces a lot.
So also patients have to keep in mind that the top of the spectacle should cover the top of the brow. So that is an ideal, that would give an ideal size of the frame. And would you like to comment on pantoscopic tilt when we are commenting on BVD?
Yes, so pantoscopic tilt is basically the angle between the visual axis and the back vertex distance. So if the patient is if the vertex distance is very low, then the pantoscopic tilt can also cause a problem. Basically, whenever we are making near vision glasses or presbyopic glasses, if the pantoscopic tilt is very low, the patient might not be comfortable with bifocals or progressives, because the distance to go from far to near becomes very low. So they're not able to adjust to that change very fast. So pantoscopic tilt is an angle that also needs to be considered when, especially for near vision glasses.
Right. So thank you so much. And any more insights, Dr. Neeraj, would you like to give, sir?
Just that when you asked a question about the type of frame selecting, and you said that, rightly said that it should be slightly above the brow. But many a times what happens is, especially the ladies in middle age, when they're using progressive glasses, I think no offense to the ladies by what I'm saying, they select some frames where the frame is too much higher over the brow for the fashion purposes. So there what happens is that when they are seeing the distance, they are seeing actually through the intermediate portion of the progressive glasses rather than seeing from the distance. So that has to be kept in mind, that whenever we prescribe a progressive, we need to tell the patient which type of frame they should not be having a oversized frame, especially when it is overshooting the brow.
Right, sir. So when any patient asks me, or when I counsel the patient, make it a point to counsel about the size of the frame also. I tell them, if you're so fond of fancy frames, please make shades. Otherwise, be more practical in selecting the frames. And as ophthalmologists, I would like to add that as ophthalmologists, one has to have a strong hold on optics, refraction, and all the practical aspects that Dr. Ritika has covered, because once we know all this, then we can troubleshoot any problem that arises during our day-to-day practice. If we are not aware, we have to depend on only optometrists, and we may not be able to satisfy our patients. So with this, can we conclude, Dr. Kaveri?
Any questions from the audience?
Yes, sir, there's one question. Is there any situation in which the decentration actually helps?
Yes, like we discussed, whenever we are prescribing for near vision glasses, or if the patient has a phoria, we can purposely decenter the glasses so that we can induce a prismatic effect that causes the eyeball to move central and allow fixation.
Especially the binocular vision dysfunction that I told you, where the phorias are very less. It's something that usually we are picking only with the Maddox rod test. So there, rather than using a prismatic glass as such, we can go in for decentration, and if patient is having a higher number, that helps us and gives us that amount of prismatic deviation.
So many a times, our students or some patients do ask that if they have squint, can they go in for progressive lenses? Yes, they can go in for progressive. And also, if a patient is pseudophakic in one eye and they don't have a near power in other eye, we can give uniocular progressive lens also. So many a times they have these doubts.
There is another question. Does decentration produce any astigmatic error or just prismatic effect?
Just prismatic effect. In fact, you can also do a decentration if there is a cylindrical power. That was a little bit more complicated, so I've not covered it. Basically, in that, you have to give a prismatic effect in every meridian, that is horizontal as well as vertical. So you can induce a decentration even if there is an astigmatic power. And no, the decentration itself will not induce astigmatism.
That's all for now.
I think we can conclude then.
Yeah.
I must congratulate and compliment you. You really, Dr. Ritika, you have covered it very well. And I think there were certain things which were eye-opener to us also. Thank you very much. Thank you, Dr. Savita, for
Thank you, sir.
moderating the nice way.
So, thank you all for joining today's webinar. Sincere gratitude to Dr. Neeraj, our chairperson, for the practical tips and inputs. Heartfelt thanks to Dr. Ritika for delivering a pragmatic, insightful, and engaging session. It was an enriching session. We hope the session has reinforced key points, practical insights, which can be applied in our day-to-day clinical practice. Wish you all the best in your work and in providing exceptional eye care to our patients. Thank you all once again. Thank you, Dr. Kaveri. And I thank Dr. Santosh Unnawar, sir, for the same.